Now, I want you to get ready for an enlightening and informative conversation with Deborah Maldonado, the Chief Administrative Officer of DirectMed Clinic, with more than 30 years of experience in healthcare and management. Deborah is a highly respected professional in her field. Her qualifications include an AAS nursing degree, a BS in healthcare management, and a master's in healthcare administration, making her uniquely qualified to lead DirectMed Clinic's success. Deborah's creative problem-solving mentality and calculated risk-taking approach have been instrumental in managing the clinic's daily operations since she joined in 2018. Her extensive experience and knowledge make her a valuable resource for the healthcare industry. So we're excited to have her on our show today to share her expertise and insights with our listeners. Ladies and gentlemen, I get to collaborate often with Deb. Well, actually, I used to collaborate often with her, and lately it is more Andrea, who is also here on stage with us. And I can tell you that whenever Deb says something, it always makes me really understand that she has years of experience in insights into nursing and how it impacts patients, but also businesses. She cares a lot about the community. So I'm very, very happy to ask the first question to Deb. And that would be, how do you see the role of nurses evolving in the healthcare system, and how can they be better utilized to improve patient outcomes and the overall functioning of the healthcare system?
Well, thank you very much, Sankar, I'm really excited to be here today. And thank you for your question. The role of nursing has evolved over many years, and of course, we've always had nurses such as in direct primary care, in hospitals and healthcare institutions, at the bedside. Case management, we've had, now they're called frequently navigators. They have further developed to be involved in establishing nursing standards and quality of care. And then furthermore, the role of nursing has really even further evolved to include things such as contract negotiations with insurance companies. That's one of the things I've done. Risk management, even forensic medicine, research educators, occupational nursing, and of course leadership roles, especially in the C-suite. But most recently, I've become very engaged in an area that I have found very fascinating, and that's informatics. Informatics has the opportunities of analyzing information, being able to be involved in designing what that looks like and implementing it. It's a great structure for a model of healthcare that I currently am involved with as it relates to direct primary care, the organization being DirectMed Clinic. And it really has taken nursing into a totally different level, in my opinion. And I think that's where I see a huge opportunity for nurses to further develop their expertise and use their expertise in further developing this whole concept in order for us to be able to meet the patient's goals. And that's a real challenging thing. And in meeting that goal, one of the things that we've developed here is what's called care journeys. And later on, I'll tell you all a little bit more about that, but I just wanted to kind of hopefully answer your question as it relates to the overall question.
Yes, absolutely, you did. And I'm so excited. What was the word info?
It's in informatics.
Informatics, okay.
Uh-huh.
Yeah, and definitely, if you want to tell us more about what you had planned to educate us on, that would be a good moment now.
Well, wonderful. One of the things and you were very gracious by just saying over 30 years. It's going close to 40 years, like by maybe 6 months in nursing and in healthcare. So thank you very much, Shankar. But I've always been in the hospital setting, in the inpatient care setting, and not until 2018 did I jump into something so totally different that I was not used to, and that was in the outpatient setting and being in a doctor's office doing helping with primary care. But the model itself, just of Dr. Muchigamba, who is the medical director, the owner of the clinic, I was just so enticed with his model, and I was actually doing some consulting work for him when he finally just said, "Can you just come on board?" And so it's been a very exciting time. At the beginning, it was really challenging because I felt like there was nothing that was available in the community or nationwide that really could help further develop the model that he envisioned for the organization, really shifting the way you look at healthcare. And it really comes down to our primary goal that I think in nursing and in healthcare in general, we always want to achieve, and that's positive, good outcomes for patients, but doing it on a financial platform that is sustainable. And I don't think that we have that right now. We have a lot of models, traditional models that kind of retrospectively look at things, quality indicators, but it's not something that you can make adjustments as you go forward when you're looking at outpatient type of care. Now, within the healthcare organization inpatient setting, I was always involved in think has the opportunity to really make a difference in patients' lives and in the community because it takes it to a different level. We're looking at patients' care plans, and what's even more difficult is just trying to shift the mindset for patients or for the community from going to the doctor only when you're sick and really looking at it, let's do it when we're well so that we can stay healthy. That was so evident during the pandemic. A lot of the questions that were being asked of us was, the management of chronic diseases. And so those by itself, if we could even impact those slightly, then we should be able to have a healthier community and be able to really help patients become healthier. But that's not the mindset of our healthcare industry. It's really, in fact, insurances, they don't pay you necessarily much for health. They pay you for sickness. And so that really is an interesting way when I came across this on how we could make an impact by being able to track patients' medical information, develop care plans, what we call journeys. And this is really new. Right now, it's in development. Literally, right now, we are putting this together. It's being designed. There's nothing in the United States that I know of that is really doing this. This is really, truly new, and it's going to take us to, like I said, to a different level.
So you really have the chance to, in your leadership role at RecMed Clinic, to impact what you all do with that clinic in a very meaningful way. So at this point, I'm really interested. I'm going to call on Michelle next because she certainly has a lot of experience in this field. But before I let her speak, again, I would ask all of you, if you haven't already, please share the room so we can get some more people in. We do have 7 awesome listeners: Shirley, Akbar, Timothy, Mariana, Dr. Kelly, Maria, and Kajat. So definitely awesome to have you here. And so click the 3 dots at the top, and then we can hopefully get some more people in here. Michelle, I had a question for you prepared, and I think you know what it is. It's, can you discuss the importance of nursing leadership in the healthcare system and how nurse leaders drive change and innovation in the field? So I think that really is a question that works well with what Deborah has just shared with us. Michelle.
Sure. Good afternoon, everyone. And hi, Deborah. I know we've met
Yes.
one other time in person, so this is great to see you on a small screen, huh?
Very small.
Thank you, Shankar, for that question. I have had a lot of experience. I'm also in the 30 plus years of nursing leadership, and in a variety of settings. And outpatient was one of them, and most of it was in the acute care forefront. And really, when we start looking at nursing leadership positions and how nurse leaders drive, their main focus is really to drive quality outcomes and be the advocates for patient safety. And that is becoming more and more a strategic role, as we see when we do hire nurse leaders, whether it is in outpatient or other types of settings in acute care. We are looking for a minimum of a master's degree right now, whether it's in nursing or a related health administration field. And for the top level of the chief nurse, they really like to have a doctorate in nursing practice or a PhD. And the reason for this is that it's the higher level of really understanding organizational change impacts, how organizational change and nurse leaders impact the health and wellness of not only just the staff, but of the community. And one of the things of this culture of safety and quality within, many times we drive the development and implementation of evidence-based practice standards of care. And I know that when we look at some value-based purchasing and looking at decreasing urinary tract infections in a hospital, one of our main focuses as nursing leaders is that we cannot have patients get sicker while they're under our care, meaning that they should not be developing an infection that was created by being in a hospital because of poor protocols and standards. And the facilitation of this is very strategic. It's a goal set of what we want our reduction in infections to be. Nurses play a part in partnering with quality departments, partnering with the physician, and also partnering with IT as well as informatics nurses to get the best knowledge about this infrastructure of creating this culture of safety. Many of times we're also part of innovation where there are some new devices, new equipment out there that suggest that we will be able to look at vital signs differently, continuously monitoring of vital signs. The astute nurse leader is going to be looking at the entire functioning of that hospital. So, for example, give you a specific example, we wanted to bring in, and we actually did implement this, consistent vital signs, because it was going to save time for our nurses, particularly in night shift, and also time for the patient to not have to be disturbed, every hour post-operatively during the night. So we wanted a continuous monitoring system. But at the same time, as a nurse leader, I found that we were also having patients come to our med-surg floors and then within less than maybe 24 hours have to be readmitted to our ICUs. So I wanted to make sure that the devices that we were bringing in and the procedures and protocols actually were decreasing the failure to rescue, that's a term we use, where our nurses knew immediately before anyone else that our patient was getting into trouble. And so one of our innovations was to trial this continuous monitoring. It was non-invasive, but trial this on one of our busiest medical surgical floors. And we found that we decreased readmissions to the ICU by 20% within the first 6 months. So this is the type of innovation that we have been called upon to really perfect and to really get across. The other thing is to have excruciating team facilitation, being able to speak and walk the talk, and also really understand the patient-centeredness. And more, as we look at the acute care and how it can combine with the outpatient practice sites, we're still working through how we can better hand off from an acute care setting to maybe a skilled nursing, a rehabilitation center, and then to our outpatient counterparts so that they have the understanding of what happened in that hospital stay, and vice versa. With the higher technology of the informatics and the EHR that's continuously being adapted, what do we know about this patient prior to them coming into our acute care settings? What do we know about this family? How are these patients learning and how are they embracing their disease state so that we can better provide that continuity of care? I think that's where we still continue to struggle from one building to the next, from one area of expertise to the other. But this is where the nurse navigators that Deb talked about come in, the care coordinators, and also those in our community that help address the continuous continuity of care that we want to provide. Does anyone have any questions of anything that I spoke about so far?
Yeah, that was certainly a lot, and I definitely want to give Deb. Usually I go to the next panelist, but Deb, do you want to react to this? Because a lot of this was very specific to the both of your field.
Yeah, I mean, I totally agree. And with Michelle, it's definitely coming up with innovative ways of trying to decrease readmissions, whether it's to ICU or even to inpatient care in general. All of those things are really important. And I think that we struggle a lot, especially when we're looking at, especially if you're in the C-suite and you're looking at budgets and that good kind of stuff. And the challenge is to try to help really promote or to support the data, support what can be done to improve the patient outcomes and patient safety at a price that the C-suite's going to agree to, and that's always a real challenge. Do you have any insights on that, as far as Michelle, on the financial aspect of it?
Yes, and so I was in the C-suite, and so number one, with the nurse in the C-suite, that is the one person, is the only one in the C-suite when you think of the chief financial officer and the chief executive officer that does have a license. And
exactly.
So that license, that's a very important role. That license can be challenged. And what we would do is, you're definitely right, Deb, about looking at data. I was always looking at data. Data was given to me, but then the interpretation of that data. And so if you are decreasing, say a urinary tract infection, which doesn't increase the length of stay of a patient, for example. Let's take something such as that. They don't go into sepsis, or we put things in place and protocols. If I was able to show, and I usually was able to show, that whatever program I was bringing in was going to decrease this amount of urinary tract infections, and that would also subsequently reduce length of stay, readmissions to ICUs, or even coming back to the emergency department, which is a very costly endeavor. I was able to promote the programs that were very sound and evidence-based. And it wasn't always about adding staff, but it was about the facilitation of nursing at the bedside, understanding the evidence base, being part of the protocols, and being part of the surveillance and monitoring. Because once that culture of safety is in place, the staff are able to have autonomy and be empowered in their practice. so that they're constantly monitoring and they don't want anything to go wrong with the patients. Most of the costs within the C-suite are, bed utilization, staffing, but when you really use the data to your credibility, and then you're able to bring in programs that will eliminate, they're for the most part, there usually is a support of that, particularly if it aligns with the goals and objectives of that hospital organization at that time.
Okay, well, there's definitely not a lot of. We have a chat going on here to coordinating everything, and it just said like this is really nurse specific, and we love that. And as always, here on this platform, try to get perspectives from all angles. So I'm going to switch gears just a little bit by getting David's perspective here very soon. And before I call on David, though, I will remind everyone that this is indeed being recorded and made available as a podcast. You can go to healthcarespeakerseries.com and you can look at the previous episodes. You can listen to them and also look forward to finding this specific episode right now on there if you want to come back to it or even share it with someone later, because LinkedIn as of now doesn't allow us or doesn't enable us to record this. But we have, of course, special techie setup to make that happen. Andrea on stage and we run and operate a healthcare marketing and PR agency out of San Antonio. We have a lot of technology that we utilize, so that's how we make that happen. Now, David, you are the doctor program liaison. You, of course, work very closely with Deborah. You know her very well. And my question to you, David, is how do nurses and doctor liaisons work together to address patient complaints and concerns and ensure that patients are satisfied with their care? David? Oh, got to bring you up again. There you go.
All right. Sorry about that.
No problem.
Okay, so I'm the hairy-legged one on the panel today. So thanks for that, Shankar. Appreciate it. It's interesting. I am the one that's on this today who I have no medical background. I have no medical degrees whatsoever. But from a kind of a street level view, dealing with employers and employees and dealing with people that are struggling with healthcare. I mean, I think most of my life, I always knew the nursing profession was the people that carried the water and they did all the hard stuff. And I think for most of my life, I think that's pretty much what they were looked upon. And I'm not sure that they were really tapped into as such an incredible resource, because I think we all know that they know more about what's going on with that patient than the doctor does. And I realize there's a structure and all of that. And I can't speak to any of that. I know that what I've seen the last few years in getting to know Deborah Maldonado is now there seems to be an awakening in the profession to say, wait a minute, the nursing profession has something important to say. We've got to put the brakes on. We've got to listen to them. We've got to trust them. And from where I sit, just on the street level, I'm seeing a paradigm shift of nurses being at the table for discussions that maybe years ago they were kind of on the outside, and then whatever the guys, whoever they were sitting in the room, would come out and say, this is what we're going to do. And immediately the nurses could say, that's never going to work. So I am beginning to see that. I don't know if that's true being inside the nursing profession, but from a layperson on the outside looking in, I do see that happening, and it's exciting to me because I think a lot of new, fresh things are happening in healthcare. And I think a lot of that is because now the establishment, so to speak, is stopping, they're taking notice, and they're listening. And I think that's better for everyone.
Thank you, David. Deborah, do you want to react?
Sure. In talking about patient satisfaction, addressing any complaints or concerns, that is one thing that as a leader you always obviously are. It's always at the top of your to-do list to make sure that we have processes in place to help. First of all, gauge the patient satisfaction. I think that especially patients, they when they go to a doctor, when they go to the hospital, I think they feel like, well, obviously if they have a license, they know what they're doing. So all they have to gauge everything on is their experience. And so that experience translates to whether you're good or bad. And I think it's important, and I know that almost all healthcare systems, we all have some form or fashion of creating or soliciting some feedback from patients on a frequent basis. And as leaders, we analyze that information weekly. In my setting, we do this weekly, but at least monthly, and look at trends and be able to address, any areas of opportunity to make sure that the patient's experience is one that's positive. It's hard enough sometimes just to get patients in the door when they're feeling well. They're not going to come. They don't want to come to the doctor, and that's in itself a paradigm shift that I hope in the future we can change, where people engaged in their health care and not be reactive and just come whenever they're feeling sick, but yet really come to try to see where they're at with their health and be proactive and try to minimize some of those chronic diseases that have affected many of us, especially during the pandemic. When it comes to concerns or complaints, those are things that need to be addressed immediately. And in most leadership, there's a whole process that that we use in order to investigate, to collect data, to meet with people, and to respond to it appropriately. In addressing any of those issues, you don't want to stick your head in the sand and hope that it goes away. You need to address it, and address it quickly. Otherwise, you obviously impact the possibility of risk related to on a legal standpoint, and further exacerbating the issue. So I think that in patient satisfaction, there's always a lot of opportunity, but you got to have your finger on the pulse to make sure that you're doing the right thing for patients and for patient outcomes. So thank you, David.
Well, thank you, Deborah. I mean, it's definitely a tough job for every healthcare professional to get us patients in there when we don't feel sick, we don't have any problems. I mean, I am the first one to admit whenever I feel okay and there's nothing urgent. I mean, I have you all at my fingertips, and yet it is just difficult to make time for that or even have the awareness. So I definitely appreciate your words, and I definitely want to make sure that I get my physical in now, because you really made me realize that's important, and you all work so hard for us to stay and remain healthy. I'm going to ask Kelly to speak soon here, but I'll give a reminder to our dear listeners that you will have the opportunity, if you wish so, at the end when the panelists have spoken, you can raise your hand and then you can come on stage and share your perspective or ask a question or make a comment. So definitely we always look forward to that part of our program. Kelly, you represent a very important aspect in the continuum of of taking care of people and healthcare, and you work a lot, I believe, understanding what you as a healthcare broker can do. So how do healthcare brokers and nurses work together to ensure that patients receive appropriate and timely care?
Hi, Shankar. Hello, everybody. Thank you for having me here today. So I was a little struggling a bit with how I was going to have anything to apply to this, but now that we've talked some more, I'm really kind of excited, because brokers and nurses, and maybe as an insurance agent and agency owner, we kind of think of things in two different ways. We think of things as traditional, and we think of things as alternative. So in the alternative space, we're finding that with level and self-funded plan creation, that the involvement of medical managers, and these are nurses, much like Deborah said about the process of the journey that they're developing for direct primary care. So when you put that in the top of a plan and you allow a nurse to work with the employees of a group plan and have them educate, have them monitor chronic condition, encourage them in healthy lifestyle, it does a huge, and it impacts hugely for the employer, because by their interaction at the top of the tier with those employees and giving them positive information and good information about their diagnosis and their disease and their care, then what they're doing is they're enabling and they're driving the cost of that care down, because they're teaching people to be healthy, and they're teaching them how to utilize their plan correctly. So instead of, being scared all of a sudden when something happens and not know necessarily how to react, they're there to guide them to the proper care. They're there to guide them where they need to go. Don't rush to the emergency room. Come see us. Don't do this. Go here. They're able to do all of those things, which is just pretty incredible, because in the thought of transparency, they are opening that up. They're opening up the ability for places like direct primary care clinic to thrive in the DPC market. They're opening up the ability for self-funded and level-funded plans to really make sense, because you're facilitating the savings of a lot of money for some companies. So I love the idea of what you guys do on that level. I think it's amazing. First of all, nurses, I don't know how you guys do it, but things would fall apart without you. Like, you're like the moms of the medical field. I feel like you are the correctors. You are the figuring out how to make things work people. And so my hat off to you guys. High five. I think it's awesome. So that's how I interact and how we are able to interact with nurses in our industry.
Yes. Thank you, Kelly. Deborah, did you want to react?
Sure, absolutely. I really appreciate working with, I do work with several of the TPAs for self-funded organizations where we have clinics inside their companies. And so what we try to do is really come up with strategies that are specific to that workplace, because you go from one organization to another and you see a totally different workforce, their needs, their challenges when it comes to healthcare, et cetera. One of the things that I have found in doing direct primary care is you can't cookie cutter anything. You really have to create a care journey, as I mentioned earlier in our talk, that is very specific to that particular patient. When you're trying to avoid, emergency room visits, avoid urgent care visits, and really staying on top of what their needs are, and being able to partner with the patient. Because if you don't get that patient involved, engaged in their care, then it really makes it very difficult to make any headway with their diabetes or their obesity or their hypertension, whatever that may be. In the program, or in the infrastructure we're creating right now in our organization with the care of our patients, the care journeys actually are something that really is nice, because we're able to invite into that care journey people that might be able to, that are part of the care of that patient. So, for example, you have a gentleman that is working the warehouse. He really could care less about his care, but the wife, now she's someone you want to target. So we find ways to engage not just the patient, but their family, whoever that may be, that might help this employee be able to not forget to take his medicine, to be able to come in when he needs to in order for us to check up on him. Be able to, of course, the spouse frequently is the one that cooks, being able to cook the way that this patient, will benefit from as it relates to his chronic healthcare condition. So the model that we're creating right now with our infrastructure and informatics allows us to be able to bring in other family members that can help us, can help the patient stay engaged. And that's really not something that I've seen in the past with any form or fashion. So we know that makes a huge difference as it relates to savings. We know that if we can stay on top of it, and then we definitely can see the savings. And the problem has always been, how do you measure the ability to say, I avoided this patient from going to the emergency room. I was able to avoid them going to the urgent care. So those things are really a challenge right now. We're trying to figure out, how do we make that? How do we quantify that? How can you literally say, this didn't happen because we did this, so therefore we saved you this amount of money. So those are some of the challenges that we have in this model, as to how do we reflect savings, except for maybe looking at past claims and hopefully seeing a trend downwards as it relates to those particular expenditures. But nonetheless, I really enjoy working, especially with the TPAs that are help us be able to quickly, if we have any referrals that need to go out, et cetera, then that's something that they help us out a lot with, in trying to get them as quickly as possible to the right place, because they get exhausted with trying to figure out, where am I supposed to go? What if it's my insurance going to pay for this at this place but not that place? And that disillusions patients from really seeking what they need to get done. So what we try to do is navigate that for them. So we wear a lot of different hats in this, obviously, in this setting, to try to make meet the goal for that particular patient and see positive outcomes incrementally, but start seeing positive outcomes.
Deborah, it's just so refreshing to hear your passion and how much you care about all aspects. And we're just all blessed to have you in our professional lives, and also to know that we can rely on you and your organization whenever we need help. At this point, I do want to ask our audience, who was waiting patiently, first of all, Shirley, Kadia, Kayla, Huda, Timothy, and Dr. Kelly, Michael. Thank you so much for having spent your time with us. And I do want to ask you to raise your hand now if you happen to have a question. It is a good opportunity to come up and participate. Michael, welcome to stage. Any questions, comments, concerns? The floor is yours. And you need to click the unmute button first. It's the button on the lower right-hand side.
Thank you so much. I enjoy the conversation. Absolutely a lot of great information around patient care. I just wanted to ask a question and make a comment, but the question was around where are you in the nursing field as it relates to precision medicine, or some may refer to it as personalized medicine. And in my work, I just noticed a gap in the conversations between sometimes what's happening, with all the great advances, and then it didn't seem to be like a lot of nurses in the room and in the conversations. So I was just wondering where, as a whole, as a healthcare system, in terms of that type of engagement.
Well, I think that as I think Michelle even brought to the point that, obviously nursing is part now of the C-suite. Early on, that wasn't the case. Obviously, in the last few decades, that's been even a Joint Commission requirement because we do, like Michelle said, we have a license, and we need to be able to really advocate for the patients. So I think sometimes it depends on the nurse, the leader, and the ability for them to be able to communicate, what is needed in managing the care of patients, whether it's inpatient or outpatient. And a lot of it has to do with the willingness of the organization to allow those things to happen, or for allow us to be able to do certain things. Finances is always a challenge. There's always budgets to be made. And frequently, depending on the organization, that's either allowed or not allowed. And even if you've got some good points to make and some good outcomes and some good planning, etc., it's still a real challenge to try to get things accomplished at times. I think that as it relates to patient care and as I mentioned earlier, very specific to the patient. The care journeys that we do in at least in my setting, very tailored to that particular patient. You've got to be able to make a difference. And what I found very interesting is that, well, not interesting in that sense, but refreshing, is the fact that when I worked in the hospital setting, that's when I got them when they already failed. They're sick. They didn't take their medication. They end up having a stroke, whatever that may occur. They ended up in the hospital. So whatever happened on the outside didn't translate, and so they end up in the hospital. For the first time, I feel like we really can make a difference in the outpatient setting, but we definitely need to be able to find a way that we can tailor our plan for these patients and have the opportunity to make a difference in their outcomes related to whatever their issues may be.
Michelle, do you want to react?
Sure, and that's Michael. That is a great question, and many of the things that we've done in inpatient. It's really hard to talk about everything that we do from outpatient, inpatient as nursing leaders, but from the time I was in nursing structures and everything always come to play and to fruition. But a lot of work done on relationship-based care models. And in the hospital setting, yes, someone might have failed, but sometimes in an aging population, at some point, there is a disease that's going to get you at some point. And so the things that we've done in inpatient and acute care, and this has been always following on the track of the patient experience. But that patient experience is about how we've made that patient feel individualized, and that we understand, even in the shortest time possible, whether it's a 2-day length of stay or it's a 3-day or a 5-day, understand the family and the needs of the patient, the family. So there's been a lot of strategy with team huddles, where nurses are, giving explicit handoffs to each other from each shift. The other is that we have more and more involved the patient and the family in the handoff. So we've opened up visiting hours so that it's okay for a family member to come in early in the morning or hear report, team conferences. And the one thing to keep communication with the patient, we not just tell the patient what to do, questions in the beginning of our nursing assessments when we're admitting them to an acute care setting of what is their primary goal and what is their objective for this hospitalization. And so then we try to meet that by having great handoffs and communication of care. The bringing of the whiteboard into the inpatient rooms and talking about their pain scale, who their physician is, who the attending is on, communicating at all lengths and extreme to these patients about what to expect in that hospitalization, but then asking them as well, when do you want to walk today? You have to walk 3 times, but when do you want to walk today? Those are the ways that we are constantly monitoring that model of care that's relationship-based and that is about what you're talking about, precision, but really getting to know the patient and not just having us healthcare providers come in and dictate what's happening. Does that answer your question for the acute care setting?
Yeah, I think very much so. And thank you all for sharing. And I do see a transition in care, in particular as it relates to sickle cell disease. So I see a lot of changes in the overall nursing field, and it's having the direct and a kind of good impact sometimes on sickle cell patients. So thank you all.
Thank you, Michael, for your great question and for joining us on stage. Do we have anyone else who wants to join, ask a question, make a comment? Now would be the time to raise your hand. I remind you that there is the domain healthcarespeakerseries.com where you will find the recording of this episode. You can also go and re-listen to past episodes. It's definitely been a great conversation as always. And Deb, if you ever get bored and want more podcast interaction, you're always welcome to come back, because I just told Andrea, you are a natural talent here for audio events. So thank you very much.
Thank you.
There we go. So let's see. Do I see any other reactions, hands? No? Okay, that's totally fine. I'm going to end us with the idea that I want you to go and explore each other's profiles, connect with each other. This is an opportunity to network. Just because right at this moment there may not be a reason to talk to each other or collaborate with each other, that doesn't mean that there won't be anything in the future. Also, follow the people who spoke on stage. It takes a certain level of courage, and the thing that you can do, and that it is for free, is give a follow. We call that social currency, right? So I'm going to end us with a song, and we'll be back again next week, I believe. Andrea will be the host. We haven't found a guest speaker yet, but if you know someone who has a powerful message in healthcare, please let us know. That's it.